Okay, I think people are um, have mostly joined. So welcome everybody to the Maudsley Philosophy Group on this kind of this extraordinary day of heat where we're all melting. So we've had to move it all, as I'm sure, hopefully you've been able to get information on all online. So this is an all online meeting and we're recording it. So it's a great pleasure to have um, Mayura Deshpande with us today. So Mayura is, as you can see on the slide, a consultant forensic psychiatrist. She's the National Special Advisor in Secure Care to NHS England and has got a number of roles really in that context across NHS England and the policy space. She's honorary senior lecturer at University of Southampton, has got a strong interest in homicide inquiry methodology, but has also got a very strong interest in ethics and law, and has been very active in at the Royal College of Psychiatrists in many respects, or in different ways, kind of wearing, I guess, all of those hats. And it's in that context that I know her. So very welcome, Mayura, to Maudsley Philosophy Group, where you'll be no doubt talking about things that are really familiar to you, but we hope this forum offers a more kind of philosophical uh, uh, um, space, and certainly one to kind of think together about this vexed issue of causation. So over to you, and welcome again.
Thank you very much, Gareth, and that's a lovely introduction. Thank you. And lovely to meet you all. I'm so sorry about my sort of technological ineptitude, but hopefully you can see the slides and hopefully you can hear me and hopefully my Wi-Fi will hold out because it's really struggled in the heat. But as Gareth said, I've been really interested in mental health homicide inquiries, well, all sorts of inquiries really, but because of my background as a forensic psychiatrist, I decided to specifically look at homicide inquiries, partly because, sadly, as a forensic psychiatrist, mental health homicide is a bit of an occupational hazard, I think, and partly because in previous roles in my trust, I work in Hampshire, Isle of Wight, and previously I had a number of sort of senior management roles in the organization, and I was responsible for quality and safety. And one of my jobs essentially was to commission homicide inquiries and to receive homicide inquiries. And another thing that I've been doing for the last sort of 10, 15 years is carrying out homicide inquiries for other trusts. And so in that context, I got very interested, both in the sort of the process, the logistics and so on, but also, I suppose, philosophically, what actually was going on in a homicide inquiry. And this is part of a sort of a fairly big research project that I completed sometime last year. And in fact, my one true interest in the whole process was to look at causation and causality, but this was the bit that I was least able to do during the formal research bit itself, but it's something that I've then been focusing on quite a lot more in the last couple of years. So I'll just start with a bit of context. I mean, you may all know all of this already, in which case, apologies for sort of going over old ground. We've had a system of homicide inquiries in England, and to a lesser extent, actually, in the other nations of the UK, but particularly in England for about 30 years. And here's a bit of a potted history. Everybody will be aware of the Jonathan Zito, Christopher Clunis case in the early 90s, but actually that was not our first homicide inquiry. Our first homicide inquiry was, in fact, the Campbell inquiry, as it says there. And that's actually what led to the development of the care program approach, which was then solidified by the Zito Clunis case. But putting CPA aside for a moment, what it also led to was a much more formalized system of inquiries. And then there were all these sort of policy points, if you like, over the years, which I've listed there. And essentially, what all these said was more or less this. So HSG is nothing but health service guidance. And this was a document, so Health Service Guidance number 27, which was published in 1994, in the wake of the Campbell and the Clunis inquiries. And what this basically said was, that after a mental health homicide, an independent inquiry must take place. And this is the remit of those inquiries. They must examine the care that the patient was receiving, the suitability of that care, whether the care corresponded with sort of statutory obligations, guidance, whether we did a good job in mental health services, a good enough job, whether professionals exercised professional judgment adequately, and whether our care plans and the role of the key worker, as it was called at the time, was adequate. Now, what's important is this is from 1994, so over 30 years ago now. And the important thing is that the fundamental scope of inquiries hasn't really changed very much at all over the years. So a lot has been said about inquiries over the years by a lot of illustrious people. So Lewis Blom Cooper, who of course wrote The Falling Shadow, sort of famously said, an inquiry must sort of find out what happened, find out how it happened, and that's really quite important, and establish responsibility for how it had been allowed to happen, in a nutshell. This was heavily criticized by particularly psychiatrists who said, well, actually an inquiry isn't really the right process to establish responsibility. And in fact, the point of an inquiry should be for health services to have an opportunity to learn and improve quality and safety. And this message then has been repeated in different ways by sort of a lot of authors over the years. And then importantly, NHS England, which came along in 2013, as you know, published the Serious Incident Framework in 2015. And then in 2023, the SI framework was replaced by what's called PISA, or Patient Safety Incident Response Framework. And these are the governance documents that determine how we investigate any adverse events in health, not just homicides. What they all say in one form or another is that the purpose of any sort of inquiry, but particularly a mental health homicide inquiry, is to learn lessons. And the point of learning lessons, if you like, is to reduce the sort of prospect of future such homicides. So that has been a common theme all along. There's also been plenty of criticism of inquiries, and I've just listed some of these here, that they have far too many aims. They try and both, in a sense, examine the standard of care that the patient received, but they also look at lots of things which really one process can't really hope to do properly. They make lots of recommendations. These are all the same over the years. They've never been properly implemented. Inquiries are expensive. We spend, and this is a conservative estimate, we spend about £1.5 million a year in England alone on independent mental health homicide inquiries. But there's a huge amount of variability in how inquiries are done, but they have, in fact, a disproportionate amount of impact on public policy. They also have an impact on the perception of patients and their families, but also the perception of the public regarding the safety of mental health services, the very rare events, and so on and so forth. An important point that's been made in recent years is that these inquiries are actually really traumatic for staff and for bereaved families. And bereaved families here refer to both the family of the perpetrator and the family of the victim, if you like, and they have been called career-ending. So there have been quite a lot of criticisms of inquiries, and then there are some justifications. So bereaved families, campaigners very much say that this is about justice. NHS England, in all of its policy documents, and previously the Department of Health, as was at the time, have all said inquiries are not about justice. Or essentially what they've said is inquiries are about learning, but bereaved families very much believe that inquiries are also about justice. And what bereaved families will say again and again is a variation of this. We need to know why it happened. We need to know how it was allowed to happen. We need to understand these circumstances so that we can do something to ensure that another family doesn't have to go through the same thing again. The other theme is of accountability, which is entirely understandable from a bereaved family's perspective. They will say, well, if we don't find out how this was allowed to happen, how will mental health services improve? And then I think there's the fourth bit, which is about political reality. And this is, I think, quite difficult for agencies to talk about, but it is there. And it's a really important reason why we continue to have inquiries despite all these criticisms. And that is that there is no politician in the land who I think would be prepared to stand up and say to bereaved families, we are not going to investigate the deaths of your loved one at the hand of a mental health patient. So we continue to have inquiries. Okay. So I'm quickly going to just describe the process I undertook, but then get to hopefully the more interesting bit, which is on causation. So what I did as part of a sort of a PhD project was I looked at 162 independent mental health homicide inquiries, and I did this at the University of Southampton. And these were all the published inquiries, so therefore publicly available on the NHS England website between 2020 and 2023. It's important to say that this is a really skewed sample. There are many, many, many more inquiries that are completed and are not published, and they're not therefore in the public domain. And it possibly would have been an idea to perhaps try and get hold of them through NFOI, but I was told that that wouldn't work. So I decided to stick to the sample that was on the public website. Anyway, so I looked at 162 reports, which involved 162 perpetrators and 168 victims. Obviously, there were a number of double homicides in the sample. And very quickly, these were my kind of key headlines. 71% of victims were known to the perpetrator. So they were friends, family, partners, including ex-partners. And this is a much higher proportion than in general population homicides. So if you look at the Office of National Statistics for homicides in England, only under 50%, so 44%, involve victims who are known to the perpetrator. So there's a much higher proportion of stranger homicides in the general population sample compared to mental health homicides. But of course, the homicides that get a lot of media coverage, including the really tragic events in Nottingham, are the stranger homicides. But these are by far the less frequent sort of types of homicides in our sample. 52% had schizophrenia. 52% also had a history of non-compliance with treatment, not necessarily the same 52%. And then the other interesting finding, which we've known about before anyway, is that the use of a sharp implement, such as a knife, is really common in mental health homicides and much less common in general population homicides. But as I say, this was one part of the project, but and these findings aren't new, by the way. I mean, all of these things have been previously noted in previous reviews of homicides, mental health homicides. Now, from my perspective, as I was interested in methodology, rather than just the findings or outcomes of mental health homicides, I also therefore looked at thematizing the findings. And again, these are not new. So it's important to say that we've known this for a good 15, 20 years through previous such reviews. So the key findings of inquiries are these in red. There were deficits in assessment, treatment, follow-up, or discharge of the patient or the perpetrator. There were deficits in risk assessment and management. There were problems in care planning and care program approach. There were problems in communication with other agencies and also communication with families. There were patient factors, and this is a sort of a catch-all term to describe a complex illness, dual diagnosis, use of substances, extremely high acuity, that sort of thing. So I've sort of brought them together under patient factors. So these are, as I say, not new findings. And I'd hypothesized at the start of this work that these would be the findings, and more or less that was the case. I'd also hypothesized that hardly any inquiries would identify lack of resource as a problem. And that was also true. So fewer than 1 in 5 identified lack of resource as a problem. So these were, if you like, the findings. Now, what I wanted to truly understand, I think, was why these factors were chosen as the causes, if you like, or the problems. But we'll come to that in a second. The other bit that I was absolutely fascinated by was this requirement that NHS England has had for a long time, that inquiries must comment on the predictability and preventability of the homicide. But NHS England has never provided definition or guidance or thresholds. So I found this absolutely fascinating. So I've got some figures here. Not all 162 inquiries actually commented on predictability and preventability, even though they're required to. So I guess there is a governance question in terms of, inquiries not necessarily sort of fulfilling all their terms of reference, but I guess that's a different conversation. What I found really interesting was that only 4% of the 130 inquiries that commented on predictability and preventability actually said that the homicide was both predictable and preventable. 86% said it was neither predictable nor preventable, and the remaining basically said it was either predictable or preventable, if you see what I mean. So the data or the figures are interesting, but what I was really interested in understanding was how they made this judgment. And I suppose not surprisingly, I didn't really find very much explanation in any of the inquiry reports about this. So none of them actually explained what they meant by preventability and predictability. None of them actually explained how they made the judgment, or what thresholds they used. I found some suggestion that the civil threshold was used, as used in sort of legal matters. So on balance of probability. That seemed to be the sort of threshold used, but this wasn't made explicit anywhere. So this, I think, remains an area of sort of further inquiry, really. NHS England have, by the way, since I've shared all these findings with them over the last 2 years, and they have been very receptive, to be fair. And what they've said is that they're no longer requiring homicide inquiries to comment on predictability and preventability, which is helpful, I suppose, in one way, but this has been received badly, I think it's fair to say, by some of the bereaved families who very much, I think, have been led to expect that an inquiry will tell them whether the death of their loved one was predictable and preventable. The other thing to note here is that a fair few inquiries seem to treat the constructs of predictability and preventability as conditional. So they seemed to assume that a homicide was only going to be preventable if it was in the first place predictable, which sort of makes sense at first pass. But I guess what we've learned from suicide literature is that perhaps predictability is a fool's errand, and it's much better to think about preventability. So there's some stuff here to be thought about. Okay, so moving on, therefore, now to the key thing that I was actually interested in, which is how they go about identifying causes. If the effect here is the ultimate adverse event, i.e. the mental health homicide, then how did they work backwards and reconstruct the chain of events? And how did they decide that something was responsible? So in order to sort of try and do this methodically, I went back to the purpose of inquiries. Now, although NHS England documents have said for a long time that the purpose of inquiries is to produce learning, and they don't actually define learning, by the way, which I hope to look at in detail another time. But if we take the common sense sort of meaning of the word learning, so overall, the idea is that we are examining care to understand whether there are things that we might do better next time. That's what I've taken away from the word learning. However, stakeholders' understanding is different. And the key stakeholders here, I think, are actual service providers. So those of us who work in mental health services, who commission these inquiries, who carry out these inquiries, and importantly, the two sets of bereaved families. Their understanding is that an inquiry will help them to understand how the homicide was allowed to occur or why the homicide occurred. And when I've spoken to commissioners in regional NHS England teams so those are the actual teams that handle the day-to-day commissioning of inquiries and the quality governance, I've interviewed a fair few of them, and all of them essentially agree with this. Their understanding, notwithstanding what NHS England says in its official documents, everybody's understanding on the ground is that an inquiry's job is to determine why and how. Okay. So the question is, how do inquiries determine root causes and contributory factors and other factors? How do they decide which key events or omissions led to the adverse outcome, so the homicide? Okay, so the first thing I found, of course, was that NHS England until 2023 mandated the use of this methodology called root cause analysis, which I'm sure is familiar to everybody. A very quick potted history of sort of root cause analysis is that this originated in industry in the last 50 or so years, so particularly in aviation industry and in big companies like Toyota and so on, where quality control is sort of king, if you like. And the idea is that if there is an adverse event, because all aspects in those manufacturing environments are controllable, it is possible to work backwards, reconstruct the chain of events, and identify the one thing that went wrong. And that is the root cause. So, I mean, I'm paraphrasing, and this is described much more elegantly in literature, of course, but that essentially is what root cause analysis referred to. Sometime in the 1990s, RCA, or root cause analysis, was imported wholesale into health. And this wasn't just in the UK, this was in Canada, the US, Australia. So all sort of major jurisdictions imported RCA, and RCA was mandated. RCA continues to be mandated, by the way, across the US and Canada. It's really only the UK that seems to have moved away slightly from it. So the idea of RCA essentially is, as I said, you can work backwards in time after an adverse event, and you can then identify one or perhaps more than one root causes. And the idea very much is not to treat the symptoms, but the cause. I don't just fire the worker who got something wrong, but try and understand why that error occurred. And that's the other thing. RCA very much is predicated on errors. So something has gone wrong. It was an error. If we work out what the error is, we can go backwards, we can correct it, and therefore that event won't happen again. That's very much the sort of basis of this. So we have been using RCA for a long time, quite badly on the whole. And the use of RCA has dwindled from 2016. So firstly, in my sample between 2010 and 2023, only a quarter actually used RCA. And I've completed a separate project looking at the validity of RCA in health and haven't found any, but that's a separate conversation. So the key thing is that we haven't had a proper methodology being used. What instead has been used in mental health homicides is what I've described as a two-column approach. And this is essentially quite simple. So in column 1 on the left-hand side is a list of things that should have happened in a particular way. So policy X should have been followed, policy Y should have been followed, and staff should have done A, B, and C. And the next column, the second column, lists all the things that deviated from policy. So that appears to be the methodology that has been used. What there isn't is any analysis of why there might have been a deviation or why there might have been a divergence from policy. So that's just to say that this is what we seem to have used over the past 15 years. What I did find, however, was that there were a lot of causal statements. So all the inquiries, every single one of them, every last one of them had a combination of these sorts of causal statements, and there were others. So associated with, was triggered by, led to, caused by, this may have caused, it was because of this, therefore, and so on and so forth. So every variation of these sorts of causal or causal statements was used in inquiries. What I found, though, on a proper qualitative analysis was that these mostly seem to make a link between the treatment and or the care of the patient, either gaps in or whatever, and the patient or the perpetrator relapsing or falling ill. Very few then seem to be able to make an explicit causal link between the treatment and the care and the homicide, or the relapse of the illness and the homicide. So something really interesting is happening in how inquiries are addressing any sort of causal chain. And in fact, in my sample of 162 inquiries, only one inquiry said that there was a direct causal link between the treatment given to the patient, the fact that he then relapsed, became psychotic, and committed the homicide. So something very interesting is going on here. So although we have a lot of causal statements being used, they are not explicit, or I'm not quite sure what it is that they're saying, I guess. Okay, so I then went to look at the assumptions that might be being made. So I've tried to make a list. So the assumptions are, or seem to be, that there was a root cause, or perhaps more than one root cause for the homicide. And as I say, inquiries didn't seem to use the language of root causes anymore, but that was certainly what they seemed to be assuming, that there was a cause, and if only we looked hard enough, we would find it. So assumption number 1, that there was a root cause for the homicide. Assumption number 2, that the cause or the root cause was a gap in the treatment and or care of the patient. Assumption number 3, and now these come from safety science or ergonomics, which is the other big sort of area of interest of mine. So the assumption appeared to be of linear causality, which is that we have a cause and an effect. So we have an event, which then leads to another event, if you like. So therefore, common sense sort of use of words, cause and effect. So that there's a cause and there's an effect. There's no feedback loop. So that cause X leads to event Y in a nice straightforward way. But in this universe, if you like, Y cannot go back and influence X. So there is linear causality that proceeds in a single direction. That seems to be the next assumption. The next assumption that follows appears to be that causes and effects are measurable. So when we look at a series of events, we can measure, we can identify, and we can measure a cause, and we can measure an event. And essentially what that seems to be saying is that we can pick out these events from a large number of other events that might have taken place at the same time. And we can say that this was an important or a significant or pivotal or sentient event. The next assumption appears to be that all of these relationships between causes and effects, or two sets of events, hold when we examine them retrospectively. So this is the assumption of symmetry. So that because these events because they proceed in a particular direction in the real world, the same relationship holds when we examine them in retrospect. So that seems to be the next assumption. Then there are some more assumptions. The assumption is that when we examine a system such as a mental health system or a microsystem or a mesosystem, doesn't matter really, any system can be decomposed into its meaningful elements or parts or events. So we can take a system and we can chop it up, if you like, forgive the vernacular, into a series of component parts so that it is decomposable. The other part of that assumption seems to be that each element of a system, and therefore the whole system, has only two modes of functioning. Either it's working or it's not working. There is no in between. So either the risk assessment worked or the risk assessment didn't work. There's no room for the risk assessment to be somewhere in between, for instance. And this assumption then also seems to apply to the whole of the mental health system around the homicide, which is that the whole of the mental health system failed because the homicide occurred. So it was not, in fact, it was not working. And just to say why this is a particular problem in terms of safety science or ergonomics is that a health system is never bimodal. In fact, no system is bimodal. No system is either working or not working. I mean, that may be true of car industries. I really am not an expert in cars and sort of aviation, but certainly in health, that is, the health system isn't, I mean, as you know, bimodal. At any given moment, it is both working and not working, because some elements are working and perhaps working, in fact, very well, and other elements are working really badly or not working at all. And yet the sum total of it pushes the process forward. So in fact, not all patients coming into health are dying or are victims of homicide, if you see what I mean. So this is a particular problem, this assumption of sort of bimodality. The next assumption then is, as I've said already, that with all of these assumptions, the sort of next assumption is that we can identify causes and effects retrospectively, and importantly, we can identify them accurately from an infinite set of other events which might have happened at the same time, which almost certainly did happen at the same time. That we can somehow, through an inquiry process, identify what these were, and we can not only identify individual events of significance, but we can attribute a causal relationship or a causal link between them. And then the most important assumption, I think, for the purpose of inquiries in the real world is the assumption of foreseeability, that once we have done this task, once we have identified important or significant events or sentient events and deemed them to be causes and effects, that then means that they become foreseeable for the next time. And what that means is that once we've decided that an inadequate or imperfect risk assessment led to the homicide, that means that we can predict that for every single instance in the future, an imperfect risk assessment will lead to a homicide. That's what the assumption of foreseeability would say in terms of safety science. So I tried to put this together and understand what this might be telling me. And the work of Hollnagel, I think, is really important here. And he's the author of Safety 1 and Safety 2. And he's described what he calls the causality credo, which is that in these sorts of systems, in health, but in aviation, in industry, which are described as safety critical industries, the idea is, or there's a credo, which is that an adverse event occurs because something has gone wrong. And therefore, through a process of deduction, through a process of deduction, we can go back and find those causes and we can treat them. The other credo here is the zero harm credo, that all accidents are preventable. And if we then stand back and think about what we've seen in mental health homicide inquiries, but perhaps across health, but particularly so in mental health, I don't really see the same in physical health so much. So there's much more of an acceptance in physical health that some bad things will occasionally happen, that side effects will occur, and so on. That I'm not suggesting that one thing is right or not. I'm just saying there's quite a difference. Whereas in mental health, I think the impression I get is that mental health, for some reason, has been decided that mental health is a zero harm area, so that all accidents are preventable, particularly the most serious accidents, if you like, or the most serious adverse events. I mustn't call them accidents, really. Suicides and homicides are completely preventable. That's the second credo. And therefore, the assumption seems to be that a retrospective examination, in other words, an inquiry, can legitimately and accurately identify the problem in treatment or the omission or whatever which led to the homicide. And if we can prevent those gaps, we can prevent future homicides. That appears to be what has driven inquiries for 30 years. And that appears to be why we still continue to do inquiries in essentially an unchanged way. We are still doing inquiries in a way that we did them about 25 years ago, because I have gone back and looked at some really quite historical inquiries, and the sorts of language, the language, the assumptions, they haven't really changed very much at all. And the other thing that hasn't changed, of course, at all is the findings. So the findings haven't changed in 30 years. 30 years ago, we said the problems are, the reason mental health homicides occur is that there was a problem in risk assessment, care planning, interagency communication with bereaved families, the victim's family, or the patient's family, sorry, and record keeping. So those themes have not changed in 30 years. So I then tried to understand the type of causation that inquiries might be relying on. This was an exceedingly difficult task because no inquiry, actually, not a single inquiry, spoke to this or even alluded to it. So I again went back to safety science and safety science literature. And that, if you like, describes this, and this I imagine is completely familiar to all of you. So safety science describes, if you like, 3 levels of causation. I know I've said types here, but these really are levels in safety science. So absolute, where X was both necessary and sufficient to lead to Y in and of its own. And in every instance of X, Y would necessarily follow. This is what safety science would say was absolute causation. Conditional causation, where X is necessary but insufficient on its own to lead to Y. And contributory. Now, contributory is really important in safety science, I've found, because it's very rare that a proper investigation will be able to rely on sort of absolute causality. That almost never happens. So contributory causality, where X was neither necessary nor sufficient, but exerted an influence, and it was important enough that it needs to be thought about. So these are the 3 levels of causation that safety science describes, and a lot of investigations in aviation particularly rely on this. So I did this really cool training with a whole bunch of aviation scientists about 2 years ago. It was in Florida, and sadly I had to do it from home online. And it really brought home to me just how different our worlds are. So aviation scientists and aviation investigators were really clear that at the first hint of trouble, the flight is grounded. I mean, we know this anyway, but they were really clear that at the first hint of trouble, the flight is grounded. I was the sole psychiatrist, the sole non-aviation person in the room. And I found myself thinking, gosh, imagine if we applied that sort of standard to mental health. At the first sign of trouble, everything would stop, and so on. Anyway, I digress. But what I have found, though, is that this sort of causation narrative is commoner in suicide literature. So a lot of recent suicide literature has started to talk about, if not explicitly about these levels of causation, it has started to talk about sort of slightly moving away from predictability and very much towards preventability, and preventability not at an individual level, but preventability at an environmental level. And in that sort of narrative, I've started to find more and more reference to, perhaps the depression was neither necessary nor sufficient to have led to this suicide. and perhaps there was more happening here than just the depression, that sort of thing. But this sort of narrative is completely absent in homicide literature, mental health homicide literature. It is just not there. And then going back to the real world, what sort of causation is being assumed by bereaved families? So when bereaved families get given a copy of the report at the end of 3 years, when an inquiry is completed, given that inquiries do not talk about this sort of thing at all, what level of causation are bereaved families assuming? So I've spoken to bereaved families. I mean, I've done this anyway for a long time because alongside all this, I have a big interest in victim support systems. Every single bereaved family I've spoken to, bar none, has assumed that if a report says that there was a problem in risk assessment, they have assumed that this was absolute, that this was absolute causation. They have understood, not just assumed, they have understood that what the report is telling them, that if only mental health services had done risk assessment better, your loved one would not have died. And I'm sorry to sound a bit sort of sensationalist. That isn't my intention, but this is absolutely what I've heard from bereaved families repeatedly. So in not being clear about the level of causation, it seems to me that we're perhaps doing bereaved families a slight disservice, because the other side of this is that when I speak to clinicians, which also I do a huge amount, and I'm one of those clinicians myself, when a homicide inquiry report says to me that risk assessment should have been better, I mean, that's a whole other conversation, isn't it? What do we mean really by risk assessment and its ability to predict and prevent homicides? But that's for another day, I guess. But when I speak to clinicians, their understanding is, well, risk assessment could have been better, but that may not have made any difference whatsoever to the outcome. Actually, it may have made no difference to anything. It may just have looked nicer on the electronic patient record. So I think the understanding of the type or the level of causation is really different amongst bereaved families compared to professionals. And then I've tried to speak to some colleagues in the media about their understanding, and that's been really difficult. And I need to do a bit more of that. But in a nutshell, colleagues in the media who report these homicides will have privately said, if you like, that they understand a bit more than perhaps they might give them credit for. They understand the nuance a bit more, but nuance doesn't sell newspapers. So there is some, I guess what I'm saying is we're taking something slightly different. Each of us, each stakeholder is taking something slightly different, taking away something slightly different from each report. Okay, then I look to see what other sort of easily applied types of causation might be useful. And there, of course, is the ladder of causation by Huda Pearl. And the reason I looked at this was because I was trying to understand what sort of activity is it that inquiries are engaging in? What are they doing? You know, we know what they're doing. They're looking through masses of papers and documents, and they're interviewing masses of people, and then they're sort of spending 6 months drafting a report. But what is the actual cognitive task that they're engaged in? Well, it's number 3 on that list, isn't it? They're imagining and they're engaging in retrospection. That's what inquiries are doing fundamentally. Because the other thing, of course, sorry, I should have said at the start, for those unfamiliar with the process, it typically takes about between 3 and 5 years for an inquiry to be completed and report, and sometimes longer. Occasionally, it happens a bit sooner. So we're talking about a process that is really quite retrospective. This doesn't all kind of set off immediately after the homicide, because, of course, as long as the criminal process is ongoing, most inquiries are told to pause. So this really is quite retrospective. So if inquiries are engaging in imagining, sort of reconstructing a chain of events, maybe 3 to 5 years in the past, and if they're engaging in that sort of process, well, Pearl's ladder of causation would have it that a key task is the use of counterfactuals. In its most basic form, what would have happened had this risk assessment been done as we think it should have been done? Would it have made a difference to the actual outcome? Unsurprisingly, hardly any inquiry actually engaged in counterfactuals. or at least maybe they did, to be fair, but the evidence isn't there in the actual inquiry report, which is all I have access to. I don't have access to their thinking. Very few, if any, inquiries actually explicitly address the question of, well, yes, staff nurse X did such and such, and Dr. Deshpande should have done this, and she didn't do it. Most stopped there. What they didn't then do was actually say, well, had Dr. Deshpande done X and had staff nurse done this, would the outcome have been different? There's just no evidence of that, which I think is absolutely fascinating. Sorry, I'm nearly there. And then the next thing I looked at was complex adaptive systems. And that's because, because of emergent causation. And again, I'm sure this will be familiar to everybody. It seems to be, in terms of safety investigations, the adoption of complex adaptive systems thinking and emergent causality is still in its infancy, really. So in the UK, we don't really do this. We talk about it a little bit, but we haven't really done it yet. And the world leader in complex adaptive systems and emergent causality and the application of that to real world scenarios like investigations is the Santa Fe University in New Mexico. But as I say, I haven't found a huge amount of evidence of us doing that in this country yet, or in fact, any country using it effectively in carrying out investigations of a healthcare adverse event, if you see what I mean. There is some acknowledgement of the emergent nature of causality in some NHS England documents, but it's not operationalized. So in other words, it's mentioned, but there's no guidance for investigators or other, whoever's carrying out investigations on what that means and what that might look like. This is all taken from some Santa Fe University publications, which are excellent. And anyway, the four characteristics, if you like, of a complex adaptive system are that it's a self-organized system. In other words, it's dynamic and living, and it's not static, and it will change, and it will change from minute to minute. It's non-linear, so there is no linear cause-effect relationship between any two events, and there is a feedback loop or phase transition. So what happens over there will in fact go back and influence other events. And it is just not possible to do a traditional cause-effect sort of linear link between events. And that essentially the best way to think about a system is a series of networks, which then have further nested networks between them. Now, all of this makes, if you like, somebody who's very interested in safety science and the application of that to the real world, this makes perfect sense to me. What there isn't yet, if you like, is any guidance on how to actually apply this to investigations, and certainly no evidence of this sort of thinking in our homicide inquiry reports. And if all of this seems a bit far-fetched, the other way that I've thought about it is, well, is there enough evidence of systems thinking in inquiries? In other words, rather than saying staff nurse X, who saw the patient 6 weeks before he committed the homicide, needs to be reported to the NMC because she didn't do X, Y, and Z. Instead of that, is there an exploration of why staff nurse X acted the way she did, or why Dr. Deshpande acted the way she did, or didn't do certain things? Is there an adequate exploration of what else might have been going on? So essentially, human factors, what were the human factors operating and what were the systems factors operating? Sadly, there's very little, if any, evidence of this sort of thinking in our inquiries either. I then looked at cognitive biases. And this was a whole separate piece of work that I did. The odd inquiry talks about hindsight bias, but that is limited to the inquiry sort of saying at the start, well, we've made every attempt to eliminate hindsight bias, but not sort of saying how they might have done that, how any of us might do that. But other biases, anchoring, framing, confirmation bias, outcome bias. And why these matter, of course, is that anyone who completes an inquiry, so there's usually a panel of 2 or 3 people. The reality is they will not be coming to this fresh. They will have read other homicide inquiries. They will be fully aware of themes identified in previous inquiries. And so they will come to the task knowing that 30 years of inquiries have found deficits in risk assessment, care planning, interagency communication, communication with families, and record keeping. So there is something very interesting that goes on in this space. I mean, equally in the real world, we can't have, I suppose, a bunch of people carrying out an inquiry who've never dealt with a mental health homicide previously or dealt with mental health previously. So some of these biases, I think, are unavoidable in that sense, and some of these are unavoidable because of, I suppose, how human cognition works. But for all that, as I say, there was very little acknowledgement that these biases might be operating. So in summary then, what did I find? In terms of causation, if you like, if what we mean by causation is the identification of causes and effects, I found what previous such reviews had found, that inquiries generally found these 5 types of causes. They found problems in risk assessment, care planning, interagency communication, communication with families, record keeping. The odd inquiry found some additional factors. In terms of causality, if what we mean by causality is some sort of a framework for understanding the relationships between events, or the relationship, if you like, between causes and effects, I found not very much really. Mostly I just found an assumption of linear causality, which, as I said before, the assumption that there is a linear causal relationship between events, and that this holds when we examine an event retrospectively, even after 3-5 years or whatever, and that through a process of sort of logical deduction, we can determine these relationships accurately. That is essentially all I found in terms of causality. And then just to sort of go back to the overarching purpose of these, do they actually deliver? Well, there hasn't actually been a reduction in the rate of mental health homicides in England. What there has been, if you look at the Office of National Statistics data, which I have pored over again and again, there is a general decline, or there is a decline in the general population level of homicides over the last 50 years, other than the odd blip. And those odd blips are generally explainable by mass homicide events, of which we've had a few, not that many. But overall, the trend is downward. But the number of mental health homicides has not reduced, and therefore the relative proportion of mental health homicides on the denominator of general population homicides seems to have gone up, if you see what I mean. But there actually hasn't been a reduction in the number of mental health homicides. Now, this is seized upon by bereaved families and campaigners as mental health services failing to learn, and that's entirely understandable. I'm sure if I were a bereaved family, I'd be saying that. I'd be saying, hang on, we've been hearing about these for the last 30 years. We're still seeing the same themes. You are failing to learn. On the other issues that I looked at just very quickly, there's really no evidence of better support for bereaved families or clinical staff. It is a little bit better than it used to be, but it's still a long way away, particularly for bereaved families. I hadn't realized until about 10 years ago that bereaved families are not entitled to any sort of statutory support, i.e. support from the state, and they rely essentially on campaigners and goodwill, essentially. And that seems like a travesty. As I've already said, no change in themes. And then I did a whole separate piece of work, but I've left it out for today, which is I looked at recommendations and actions. And what I found, it's not funny really, but it did make me laugh, is that I've already described the outcomes or the findings of the inquiries. They said there were problems in risk assessment, communication, care planning, and so on. Those are consistent themes in inquiries. The recommendations, however, then have very little bearing or very little relationship with those themes. And then the actions that are put in place have even less of a relationship with the actual themes and the recommendation. So something very interesting, I think, philosophically or conceptually is happening in that space. So the problem we find, if you like, the problem was that there was a problem or there was a gap in care planning. The recommendation generally then is staff must do better care planning, which sort of perhaps makes sense, although anyway. The action usually is to send staff away on more training on care planning, even though there's no evidence that it was the lack of training that was the problem in the first place. So we do certain things as a matter of habit, and we like doing those things. So we like doing audit, we like doing training, and we like writing policies. Perhaps like is a bit unfair. We do these things. These are the types of things we do. We change policies, we send staff in training, and we We remind people. That's the other thing we really like doing. We email everybody to say, please don't do this again, or please do this in the future. There is zero evidence that these sorts of interventions make any difference. But I digress. And so, in the spirit of trying to be constructive, I've been working with NHS England to try and see what we might do instead. Now, as I said, the political reality is that we're not going to be able to stop doing these inquiries, however flawed they may be. And I'm a realist. So if we must do inquiries, is there a way of making them a bit more conceptually meaningful and a bit more practically useful? So I've made a whole bunch of recommendations to NHSE, which they have accepted, but we will have to see how this all proceeds. So I've said clarity of purpose. So we need to be really clear. Are we trying to determine why the homicide occurred? In that case, this is a fool's errand, is my view. And I'm not sure that we are going to be able to determine why the homicide occurred. If, however, the purpose is to examine the standard of care, that may be something we can work with, although even that is beset with problems. We do need, I think, a scaffolding of complex adaptive systems. We do have to move away from linear causation and try and think of causality as something that emerges. And we need, and I put that in red here because I guess that's one of the things I've been really interested in. We need some clarity about causal types or causal levels. And if we identify causes in inquiries, I think it's really important for the system that the inquiry is clear about what level of causation we are talking about, conditional, absolute, contributory. And I think this is really important because I think we're selling a bit of a myth otherwise to the public and to bereaved families. And then I've made other recommendations about how we might be able to develop a methodology that's based on systems thinking and human factors, causal analysis. Now, I think no matter what the purpose of inquiries is, some level of causal analysis, I think, is unavoidable and necessary. Otherwise, this is a meaningless task. Some level of causal analysis is necessary. But I think what, therefore, we need to do is be honest about it. Because at the moment, our guidance documents don't actually, aren't really honest about this. We sort of fudge it and we say, well, it's really important that we learn. But we shy away from saying actually some level of causal analysis will be needed. And I think we should be honest personally. And I think finally we need to manage the expectations of stakeholders. But that's a sort of a wider governance, I think, issue. And that I think is going to be a really hard thing to do because what our bereaved families have learned over the last 30 years is that each individual mental health homicide will result in an individual inquiry. And I'm not sure we have enough to show for it. I mean, quite apart from how much public money we spend on it, it's the sort of the emotional toll it takes, I think, on those who are part of such a process. And that's not just staff, but very much bereaved families. So I speak to some bereaved families now who've had a report for the last 7 or 8 years. And I think we might perhaps sometimes glibly assume that, the inquiry is finished and they've got a report and there's closure. There is no such thing as closure, is there? Not in this world. Not, I've sort of learned never to talk about things like closure. And I think a lot of bereaved families sort of live, anyway, that's, I guess, a whole other, but there is something about managing stakeholders' expectations in this space. But I think those are all my slides, Gareth.
Well, thank you very much, Mayor. Fascinating talk there.
May I stop sharing? Is that all right?
Yeah, why don't you? Yes, by all means. Some really interesting research and that you've done there. I mean, we'll open up to questions now while people are collecting their thoughts. I mean, by all means, share. Come on screen. Put your video camera on if you want to ask a question, or if you prefer not, you can also use the chat function. So let's open it up and just get a sense of questions coming in. So we've got one question from, is that Quinton? Is that your hand up? It's like a physical hand. There we are.
The physical hand.
Very good.
Shall I ask a question?
Yeah.
Myra, thank you for that. That was really interesting, actually. Very, very thought-provoking, very rich. A couple of thoughts, actually. In your research, did you analyse who conducts the inquiries?
Oh, yes.
Because it seems to me that I've got some experience of working in different medico-legal settings, sort of criminal cases, also personal injury. And it seems to me, just as one observation, I think lawyers, barristers, judges, I think are, as a rule, they're more trained in and more confident in attributing causation for the basis of determining responsibility, either criminal responsibility or corporate responsibility. But of course, the actual implicit models of causation and the standards of proof differ between the criminal law and personal injury. But so I do wonder that if it is the case that it's predominantly healthcare practitioners who actually conduct the inquiry, that one of the reasons about a reticence of drawing links between an analysis of events that may have contributed to deterioration of mental health, that may have increased risk, the final leg of that set of causal inferences is actually because people feel that they're not trained to comment or address on such weighty substances. It actually belongs to other disciplines. It's the sort of thing that lawyers do rather than healthcare practitioners. And there's something about the moral weight of that inference which seems to require a special profession to deal with it. But equally, it is not something that we're trying to do. That I'm often aware when there's this sort of convention of deferral. So deferring to other experts on a particular matter. So in other words, even in personal injury cases, which do recognise complex causation, an expert is called in because they are recognised as having an expertise in a particular bit of reality that corresponds to their expert, whether it's psychiatry or orthopedics or neurology. But you don't go outside what it is that you've been trained or what you're officially recognised to be an expert in. So I do wonder actually that it's not merely an absence of a sort of developed theory of causality or causation that is hampering the inquiries. It's also implicit conventions about what healthcare professionals are or are not entitled to say.
Quentin, thank you. And yes, I did. I mean, I agree entirely. And I looked specifically, and I had a slide, but I took it out in the interest of time. I sort of ended up with 50 slides otherwise. And I did look at I looked at panel composition in each inquiry. And I specifically looked at things like expertise, conflicts of interest, all of that. And in a nutshell, fewer than, I think, 2% off the top of my head had a legally qualified member. And that was very much in the earlier part of the process. So involving a legally qualified member has very much fallen out of favor over the last sort of 15 or so years. But it's sort of more problematic than even just that, because many inquiries appear to have been conducted by people who have no particular expertise in conducting inquiries. So not only do they not have legal expertise, but they seem to be, well, whoever really. And part of that, I'm afraid, is how we manage the actual logistics of the process. So what happens when a mental health homicide occurs is that the work, if you like, is commissioned through the procurement portal of the NHS, and companies are invited to bid. And I'm afraid, unsurprisingly, the cheapest bid will win. So there is that side of it, I'm afraid. The other thing I very much found was that, particularly over recent years, so between sort of 2017 and 2023, inquiry panels got smaller and smaller, and I imagine that's also to keep costs down. So by the end, it was not unusual for some inquiries to be conducted by a 2-person panel. So anyway, yeah, I do agree. I think there's something really interesting about who does inquiries and why. And I say this as somebody who's done a number of these inquiries herself.
I think just to follow up on that, and with personal injury, there's a balance of probability criterion applied, but actually also there's an interest in the but-for scenario, so the counterfactual scenario. So, and actually, I think that type of reason. So, there's a recognition of complexity that causes a multiple. But the question that you're asked to comment on is but for the accident, or but for the event, or but for the omission of care, or whatever it happens to be, would the injury have arisen? Which is actually mutatis mutandis, it's actually relevant to these homicide inquiries as well. It's just a different type of personal injury, homicide is. So it seems to me that actually it's odd that there's such a developed body of law and procedures in which people actually pay out hundreds and hundreds of millions of pounds in compensation every year to manage people who are critically injured as a result of medical negligence or road traffic accidents or industrial accidents. And that whole system is not applied to homicide. It's odd.
I mean, absolutely. These inquiries are not statutory. So they have no statutory basis. They have a basis in policy. And there's a whole set of other problems that arise as a result of the fact that these aren't statutory. And you'll be pleased to hear anyway, Quentin, that one of the recommendations I've made to NHS England very much is the but-for. That if we're going to identify factors as causes, and then at the very least, we need to be able to satisfy the but-for principle.
Thank you.
Mayura, can I ask, I mean, it was the slide that you had on assumptions was so interesting to see, because it looks as if, I mean, the overall impression you give, or I'm left with, is just how unprepared conceptually these inquiries are for what they're getting, basically. But in the assumptions that you uncover, that looks as if, to me, as if essentially that the inquiries are assuming retrospectively that the system is behaving deterministically.
Yes. Yeah.
But you might think, well, why are they making that assumption? I mean, they could assume that, the system is behaving stochastically, that it's just full of random elements and so forth. But they're not. They're assuming it's behaving as a deterministic system. And then, they're probably, no doubt, they're also very largely excluding higher, issues around free will. I mean, if given that they're interpreting the system deterministically, that would be outside of the conceptual scheme.
The framework. Yeah.
So that looks extraordinary to see. I was so struck by that slide. But then you also showed data that, well, I think it was 84% of the inquiries are saying that the outcome, namely the homicide, is neither preventable nor predictable.
Yes.
Which seems like almost the other extreme. I mean, it's almost nothing.
Yes.
It'd be very odd to think of anything as entirely unpredictable or entirely unpreventable. So there seems to be a real conceptual instability in these inquiries, to the point that you sort of think, well, is the question not, why aren't they making things better, but why aren't they making things worse? You might think that's the more relevant question to ask. Why is it that they're not making things worse?
That is exactly the point we got to. So in one of the sort of meetings last year, or perhaps earlier this year, I can't remember, where I presented the final bit of this to NHS England, I think that was very much the point that people got to, which is sort of a sense of, goodness me, not only are we potentially spending a lot of public money and making promises and so on that have no conceptual basis, but are we potentially just identifying the wrong things at the expense of other things that we ought to be focusing on, which was sort of a variation, I think, of what you've described. And as to why, I don't know, but certainly when I've done inquiries, the only way to make any sense of the whole process of doing an inquiry is to assume a deterministic system. And if inquiries, I think, started off at any other point, it would sort of render the whole thing invalid, wouldn't it? So I think there's something very interesting that goes on there. I think the only way to conceptually make sense of this whole business of inquiries is to make the assumptions that they have made. I think if those assumptions weren't made, I think we would. I mean, my conclusion, and I'm sure this will change the more I work on this, but my conclusion so far, I think, is that, as I said before, the way forward is to provide a scaffolding of complex adaptive systems, which then leads us, I think, nicely to thinking about not linear causation, but perhaps a set of random events, perhaps events that have feedback loops, perhaps events that self-organize in a small sort of mesosystem. I mean, a mental health service is probably a mesosystem, isn't it? If the macro system is the NHS or the country. And perhaps that is the way forward. Because the other thing I've realized, and sorry, I know I'm not necessarily answering your question, but the other thing I've realized is that all of this conceptual thinking needs to be operationalizable on the ground. And unless it's operationalizable, it won't change practice. In other words, a team of 3 people, perhaps a psychiatrist, a nurse, and a social worker who undertake an inquiry have to be given, and this is not me questioning their kind of expertise or anything, but they have to be given a methodology and they have to be told, this is the methodology you must use and this is what it looks like. And the using of this methodology means you will start here and you will end up here and then you will end up here, and these are the steps you must undertake. Because if we don't do that, we are going to get enormous variation. I mean, you could say, well, we have enormous variation now, and we do have enormous variation in terms of quality, but we also have quite a lot of sort of convergence on these assumptions, if that makes sense.
Thanks. I'm just turn my fan off. So let's open it up a little bit. I can see there's some comments and some questions in the chat. So should we just move to that, take a couple of those? Mayura, shall I read them out in case you've not got them?
Yes, please.
To hand. So the first is, if learning is the aim, would machine learning, thinking of AI, offer a better and cheaper option?
I mean, possibly. I cannot pretend that's an area of expertise of mine, one way or another. I suppose as a non-expert in that area, I guess my question would be, what is it that we would be asking machine learning to do? We would still be providing the system, I guess, with the base material, which is the same material that human panelists have. And perhaps AI would be less, I don't know, but perhaps AI would be less likely to suffer from cognitive biases, I don't know. But they would still be looking at the same material, and somebody would still need to interview staff and so on. Sorry, I probably just displayed my complete ignorance of how AI might work in this field.
And then should we take one more from the chat? This is about the potential link between the relapse and the homicide. So the relapse of the illness and the homicide. Presumably the criminal court essentially displayed a view through diminished responsibility in hospital disposals. Was there any link between such outcomes and the inquiries? So that's quite a forensic psychiatry question.
I did look at that separately as another piece of work. And interestingly, the link I found was between the panel's determination of predictability and or preventability and the outcome at court and the disposal. So there was a very definite trend, if you like, where the Crown Court found, if you like, diminished responsibility or manslaughter on the grounds of diminished responsibility. Panels were more likely to say that the event was predictable and preventable. This was a trend, but a definite trend. And I think the assumption there seems to be, as best as I can make out, that diminished responsibility and manslaughter, rather than murder, presumably is talking to the fact that the person was mentally ill, and that could be proven at court at the time of the offence. And therefore, mental health services should have seen the relapse or the illness. And therefore, this was predictable, and therefore it was preventable. That seems to be the thinking.
So I'm keeping my eye out for people on. Yeah. So George, you've got your physical hand up. Do you want to come in at this point?
Yes. I have to admit that I was a half an hour late joining this meeting because I was at another meeting. But I refereed the paper originally, so I'm assuming that, and I haven't gone back to the paper, that it's more or less as it was, because I certainly recommended that it should be published. And in the paper, in my comments on the paper, I said, having read the paper, I suspect that many readers will ask whether we've learned more from 162 investigations of the types usually conducted than we would have from, say, 50, with a saving of around £800,000, or even fewer. And then I said, furthermore, how meaningful can the findings be, even with investigations of large numbers of patient homicides, for example, if there are 50 perpetrators with a psychosis per annum, that is around 1 in 7,000 patients with a psychosis at any one time, it's an incredibly rare event. Even given the best risk assessment instruments so far developed under research conditions, the false positive rate will be in excess of 99%. That 86% of reports stated that the homicide was neither predictable nor preventable is likely to be a gross underestimate, I would say. And hindsight bias, extraordinarily difficult to overcome, presumably plays a role. I mean, there's work on hindsight bias where people were told, watch out for hindsight bias, and the effects still remain very strong by comparing certain information. So one of the questions I have, there was a writer some time ago when I was reviewing this who said, well, these homicide inquiries essentially exercises in rhetoric. It's to reassure the public, oh, we've done this investigation now, we understand what is behind this, and don't worry, it won't happen again. That was the... and the other person who's interested, and this is an economist, I think his name was Frank Knight, who said there's a difference between risk and uncertainty. And I think that homicides are so rare, so diverse in the backgrounds. People's lives vary enormously, that perhaps the idea of risk assessment is not appropriate for a phenomenon like a homicide by a patient. And that we should be thinking in terms more of uncertainty, and then what is the point of these inquiries? What is important, though, and the point you make, I think, very important, is what about the bereaved? What that is, one argument for having an inquiry is to say to the bereaved, look, we've looked very carefully at this, and this is what we think we've found. That may not be the best way of dealing with the grief of the bereaved. So I don't know if you covered these things in your talk, and if maybe you've said some of these things, and I don't know.
George, thank you. I've covered some of them, but I have in fact looked at all of those things in the actual sort of work, but obviously chose particular things to present here today. I mean, obviously, I completely agree. I think if it were up to me to determine how best to use this public money, I'm not sure that I would recommend continuing with the current system of inquiries that we have, these non-statutory inquiries. But I mean, I did say earlier, there's a political reality to this. And, people in charge of this sort of thing have privately said to me, we're not going to be able to stop doing these inquiries. We all understand the problems, the conceptual problems, the logistic, we understand all of those things, but we're not going to be able to stop doing these inquiries. I mean, they are still very rare events, but there's always a debate about how rare they are. It depends on who you ask, I guess. Campaigners would have it that they're far less rare than is made out. It's all very emotive. But thank you for recommending my paper for publication.
I would have thought 1 in 7,000 patients per annum is rare. Meets my definition of rarity.
But oftentimes people will respond to that, Amoira, won't they? The frequency issue by just emphasizing the impact So, risk is always a multiplication of probability and harm. So if you take harm to infinity, you're getting very, very high risk.
And every death is a terrible event, and we should try and prevent it. No one can argue with that, but reasonable attempts to prevent it would be preferable.
Yeah. Rob, is that a physical hand? Is that okay? Yeah, but I just wanted to see who's coming in. Do you want to come back just before you ask that, Rob? Mayura, did you have any comments in response?
I was just going to say, thank you, Gareth. I was just going to say that the suicide prevention world, I mean, as the term describes really, has moved on from suicide prediction at an individual level quite a bit. And I think there's very good acceptance now that the way to manage suicide as a public health emergency is to look at environmental controls. And those are the things that work at a population level rather than trying to predict the risk of suicide in an individual, particularly over a longer period of time. And there are some, there is some good work in that. So, for example, Professor John Crichton at Edinburgh University for a long time has been championing safer knives. And that seems really quite relevant to mental health homicides, given that knives are the single most commonly used tool, if you like. So it seems to me that there is something here about moving away from sort of prediction at an individual level, which as I see it, that's just never going to be possible, particularly over a period of time. I mean, if I'm in clinic and a patient is brandishing a samurai sword at me, I think we can all agree that the risk of a homicide occurring is probably quite high in the next 5 minutes. But my ability to predict the very same patient committing a homicide over the next 5 years is probably going to be quite poor. So, any prediction we make needs to factor in the time element. I mean, that is the reality for a forensic psychiatrist. I'm often asked to do risk assessments on patients. I spend my life doing them. And I always say, I can tell you what the risk is for the next 3 days. I cannot tell you what the risk is beyond that. And so on and so forth. So it seems to me that the thing that, because within NHS England, my job is policy, isn't it? And it seems to me that public policy for mental health homicides needs to move away from this business of trying to predict and move to thinking about population level interventions like we've done for suicide. It will be harder for homicide than it has been for suicide, but it seems to me that that's where we ought to go. Sorry, that's what I wanted to say.
Yes, I mean, drugs and alcohol are involved in a huge percentage of these homicides, aren't they?
86%.
So one would argue for better services for people with drug dependence.
Absolutely. Yeah. Absolutely.
And also perhaps a better kind of inquiry is to do an audit of the whole unit.
Yeah.
How are they dealing with patients, and then they might learn about, but that's not, I think, answering the societal need, which is to say, what is the cause of this? Who's at fault?
Yes.
Who's to blame for this? Yeah.
Now, Rob, I know you've been keen to ask a question, so do you want to come in at this point?
Yeah, sure. Thanks so much for that talk. It was, I really enjoyed it. Thank you. So my experience of the homicides I've been connected to, and also I suppose watching the Nottingham inquiry just recently, is that because in English law we only have, as I understand it, these 2 categories of murder or diminished responsibility. I think there was a move in the early 2000s to have a sort of second degree category that would allow, perhaps, I don't know if Gareth was pointing to this, in terms of keeping some sense of free will or responsibility or something, even in those with mental illness. But because we don't have that, the moment we move away from murder, there's suddenly this immense need, understandably, to say, well, who's at fault? And I think then, as we all know, the pressure on mental health services becomes absolutely enormous, and on the individuals themselves, and particularly the psychiatrists, and those of us who've been involved know that it can be absolutely crushing. I was interested in your point that there'd been no change in the homicide rate over time, and I wondered how far back the data went for the mentally ill. If it went right back to the asylum era. I read a few reports, I think, at one point from the sort of late 19th century, where people were trying to make sense of horrendous homicides in Europe, and they had some kind of legal process to try and make sense of it. But if you go through that period right through CPA. And now with integrated care, so I was involved with an informatics project that showed out of the 20,000 people with schizophrenia-like illnesses under our trust who are alive, who we know about, 3/4 have been discharged to primary care. So with no follow-up or supervision. Now, does that make a difference to homicide rates? I mean, I assume that there should be more supervision because, of course, like in Nottingham, he was discharged, and people now say, well, it's a problem with discharge. But has there been any difference in rates since the asylum era through the good years of CPA to integrated care now?
Thank you, Rob. I think part of the problem is that I've looked far and wide, and it's really difficult to find a data set labeled homicides by the mentally ill, and you have to slightly sort of infer it. So I've had to sort of triangulate different data sources. So I've had to go back and look at court data, which of course aren't. There's no centralized court data system in England, sadly. I've had to look at sort of diminished responsibility. And a really interesting thing I found is that no matter what the population level of homicides is, and as I say, that there's been a downward trend over the last 50 years, every year, approximately 5% of all homicides get diminished at court. So that sort of slightly suggests that the threshold for diminished isn't set. And of course, these things are never set, are they? They exist in relation to other things. So the first thing to say is that it's actually really hard, I think, to get accurate data. I'm not sure they exist in that form anywhere, and you do have to slightly bring together different data sources to try and work out what the rate of homicides by the mentally ill is. Certainly, the published inquiry numbers are not at all a reliable estimate because only a proportion are ever published. And I've done a separate piece of work looking at why we don't publish them, which is at the moment sitting with NHS England to ponder over. Your other point about sort of these rather blunt categories, we've got murder and we've got manslaughter on the basis of diminished. And then for a very small number, as you know, we have not guilty by reason of insanity. I mean, those are vanishingly small every year, and an even smaller number of unfit. Obviously, this is something that campaigners have talked about sort of degrees of culpable homicide and whether that would be better. I mean, the other thing very quickly to say again is, not only is this a problem in the eyes of campaigners, this business of murder or manslaughter and nothing in between and nothing after. I've also concluded that, our system of sort of forensic services looks the way it is because of our legal system. So in other words, once you've got somebody who's had, who gets a finding of manslaughter on the basis of diminished at Crown Court, chances are they're almost certainly going to get a hospital order disposal. And that's why our forensic beds are full of hospital order patients. And so I think it's probably, what somebody clever needs to do in policy is put all these things next to each other. And then I think the answer starts to emerge. If we look at other jurisdictions that don't have murder, manslaughter, and don't have a Section 37 hospital order disposal. So as far as I can make out, we're the only country in the world that have a Section 37 hospital order disposal. Most other countries have a 45A, which is a hybrid order. So you do some prison time and you spend some time in hospital. So essentially you come to hospital, you get treated, and then you go back to prison, or you go to prison and so you sort of repay your debt to society, if you like. We are the only country, as far as I can determine, that has this complete diversion system. And I'm obviously an immigrant, etc. And when I first came to the UK and learned about these things, I thought, gosh, this is exceedingly humane. What a humane system. I still think that, but I think I might now be in a minority. Sorry, that's taken us slightly away from what you were talking about. But I think what you've said there about murder, manslaughter, I think it has enormous implications for what then happens in other parts of the system.
Okay, so we've got quite a few questions in the chat, and then I can see we've got some more, as it were, I'm just calling them physical hands. I'm just wondering whether, I tell you what, let's take one in the chat, and then Quinton, you've got your hand up, I see, but we might be able to get through these in time. So this is one from in the chat, which is, did NHS England just it's really to confirm, did NHS England really say why they removed the need to comment on predictability and preventability in inquiries? Was it a reflection on the fact that, as you say, so many inquiries were omitting doing so, or to do with a change in feelings of its necessity?
Well, thank you. I'm afraid I'm not entirely sure. It's probably a combination of both of those. There's also, I think the third factor is probably that there has been some well-reported criticism from bereaved families, whose homicide was deemed to be not predictable or preventable. And I suspect it's a combination of these factors. Now, unfortunately, it's not so much that NHS England have sort of sent out a thing saying we don't require you to comment on predictability and preventability anymore. It sort of happened over a period of time. So at the moment, inquiries that are being published now, say in the last year, some of them still have commented on predictability, preventability, others haven't. So it's really not that clear. But NHSE have certainly said to me, in a sort of recorded meeting, that they will remove the requirement for inquiries to think about this.
Because you might think that they could have said sort of more useful things like, as you were pointing out, you can't predict at an individual level. You may be able to predict for groups, but you can't predict for individual levels. And that in thinking about preventability, make sure you understand the concept of a contributory cause, rather than absolute cause. These sorts of things.
Absolutely that. But I mean, as I say, I presented all this, and I sort of offered to share my data, and I made these recommendations, and they have accepted these things. I agree with your wider point, which is, for example, NHS England might, the other thing I found very much is that, what are the 2 or 3 things that we know from research, which is accepted, and it's sort of, it's a settled issue. It's not in debate anymore. What are the factors that appear to be associated with a completed mental health homicide? Untreated psychosis, particularly with persecutory delusions, is one. Substance use is another. So the risk, when you have substance use, the risk goes up enormously. And the third thing probably is sort of being lost to follow up, or failure of engagement, as we call it. These seem to be the things that are more likely to result in serious violence or even an act of completed homicide. Well, NHS England could instead say to inquiries, please refer to the published research on the risk, on the link between mental illness and serious violence or homicide. I mean, I should be clear, the research is all not on homicides, it's on the link between mental illness and serious violence, and we have to slightly extrapolate from serious violence to completed homicide. Now, if inquiries were actually making these points, if inquiries were saying something about people being lost to follow up, or failure of engagement, or the importance of treating psychosis assertively, that would be one thing, wouldn't it? Instead of sort of focusing on the organization's policy on X and Y was out of date, and Dr. Deshpande hadn't completed her statutory and mandatory training, and the staff team was out of date for information governance training. I mean, these are typically the sorts of findings that inquiries find. Anyway, I digress again. But yes, we are in a strange place, I think, with this, where I think I'm very pleased because they've accepted my recommendations and they seem to be wanting to move this along. But I'm trying to work out how we then get it to move along a little bit.
Yeah. Quinton, you had your hand up earlier. Do you still want to come in, or?
Yeah, I'll try to do so. Try to do so succinctly. I'm just sort of prompted by the discussion to think really about forensic psychiatry and what forensic psychiatry is in the broadest terms, and what counts as good forensic psychiatry and less good forensic psychiatry, both from a practitioner point of view, but even from a training point of view, because obviously forensic psychiatry is predicated on the notion that there is that in some individuals there's a link between mental disorder and risk of violence or criminality offending. And in some ways, of course, homicide events are rare, but they are markers of they're particularly extreme outcomes of serious violence. And I think actually the link between serious violence and forensic psychiatry is an important one, because actually good forensic psychiatry and good forensic psychiatry systems will be effective in reducing the association of untreated or undertreated mental illness with serious violence. And so therefore it seems to me that in a way, the point about saying homicides are rare events and so they're sort of inherent, there's nothing one can learn about them because they're so rare, it should just be regarded as sort of bad luck, I think is probably, that's probably incorrect to the extent that one can also, in these exercises, distinguish between good practice and less good practice, whilst recognizing that human behavior is complicated, it's multiply constrained and buffered often by lots of other factors which then moderate the likelihood of progressing to events. So the point I want to make here, I mean, that's a reflection really, but I'm quite interested actually in what you think, because one reading of your talk actually is a sort of skepticism about the idea that it's possible to, the individual case, to make inferences about quality of care and homicide as an outcome. Now, I think in many cases that may be the case because of this complexity and stochasticity that we're talking about. But I suspect that in other cases, you read the notes and think, oh my God, why didn't they administer a depot medication? This person is a relapsing, remitting illness. The nature of his disorder is that he thinks his neighbour wants to kill him and is threatened to kill him and has tried to kill him when he's relapsed. Why didn't they give him a depot? Why didn't they make sure that happened? And so I just want to sort of invite your view on that. I in general, yes, I accept stochasticity, complex systems and so on. But in your work on this, do you think, ouch, they really should have done that?
Quentin, thank you. And I don't disagree at all. I did this thing a few years ago, before I started this sort of formal research, where I asked for permission to read 50 case notes. I mean, it took me a long time. And it wasn't possible to sort of case control them or match them in any way. But really what I wanted to prove, which I did go on to prove, I think, to my own satisfaction anyway, I wanted to prove that, I mean, you're absolutely right. If we examine the case notes of a patient who's committed a homicide, we will find many problems. The thing is, we will find the same problems in the case notes of patients who haven't committed the homicide.
What about serious violence? Sorry to cut in.
So
if we turn homicide into serious violence, make it a wider category, is there good forensic psychiatry which reduces serious violence and less good forensic psychiatry that doesn't reduce or fails to reduce serious violence?
I mean, yes, the answer to that is absolutely yes. But the important thing is, unfortunately, forensic psychiatrists like myself only come in after the fact. So most of these homicides occur in adult mental health. And people like me come in afterwards and look wise and say, well, of course, you should have started a depot. And of course, you should have done this and that. And this is a frequent criticism from my adult mental health colleagues who say, well, it's all very well for you. You come in after they've had it diminished and your job is to, etc. So I think that is fair criticism. But I think the same thing holds whether we look at completed homicide or serious violence. So obviously, one of the things I do in my day job is I provide risk assessments to colleagues in other parts of the system. So these are generally adult mental health colleagues who have a risky patient and they want me to go and kind of give them advice. And I do an open access clinic once a month where nobody needs to make a referral. Colleagues are welcome to come and discuss cases and so on and so forth. And the same things are seen repeatedly. And increasingly, I think, I remember when I was a trainee 20 odd years ago, a senior lecturer saying this to me at the time. She said, you know what, instead of worrying about who will go on to do bad things, we should treat people well, as in we should give them access to good treatment at an early stage, and we should be evidence-based, and we should be kind and compassionate, all the kind of good things. And I'm really sorry because this is such a corny thing to say, but increasingly my view is that, when I see somebody really risky in clinic or whatever, or I assess them or whatever, And then I spend an inordinate amount of time kind of worrying about what I think the risk of completing a homicide is, or more usually, it's not so much that. I'm thinking, what are the risks of engaging in serious violence over the next 3 years? Increasingly, I think, well, I don't have an answer to that, actually, because an infinite number of things might happen which might influence that. And I have no way of knowing one way or another. What I do know is that if they're psychotic, they need access to good treatment, and that needs to be assertive. And we need to use the Mental Health Act if that is applicable, and not worry too much about other things. Anyway, you know what I'm trying to say. I think that's sort of where I'm increasingly going. And increasingly, all of my reports are starting to look very similar. Because I say, well, I know you want me to predict their risk of harm, their risk of doing X, Y, and Z in the next 5 years. I can use fancy tools which are validated, but I can promise you they won't give you the answer you're looking for. I think it's much better that we treat them well and do sensible things. Sorry, that's really corny, I know. But
No, that's thank you very much. That's a good answer.
So we've got some more questions in the chat. So David, yes, I see you've appeared. So because you've got one in the chat, do you want to just ask it?
Yes,
Yeah.
thanks. So I deliver training for social supervisors about working with conditionally discharged patients, and I tend to use there's not that many homicides involving conditionally discharged patients, but I use those as case examples. And I'm just wondering, what's your view about that? Is that a good idea? How do we train people when we are dealing with these such rare events?
Thank you, David. In fact, my views changed over the years. So I used to think it was not a useful thing to do, sort of 10, 15 years ago. And then at the time, I had this kind of trust-wide role for quality and safety and sort of learning systems, whatever that means. And I heard repeatedly from colleagues that, in fact, there was some value in hearing about these very rare, very tragic, kind of catastrophic events. And I was really curious about that. And what I realized was that a lot of people said to me, I'm sure this is not a universal view, but a fairly commonly held view was that actually it's really useful to hear about these because sometimes these things stick. And, we had and this was not a homicide, but in our organization, we had this really tragic case of an elderly, of a lady who, in a nutshell, she came to harm from an oxygen tank. And it was not to do with the usual sorts of things that go wrong with oxygen tanks, but something else altogether. And it was rare, and it was very tragic. But a lot of colleagues said they found it very useful to be told about it and to sort of go and check that their oxygen tanks didn't have this particular fault, whatever it was now. So I suppose if people find it useful, it's not a bad thing to do. I'm still not sure what the actual value is. But then I'm very aware that I'm saying this as somebody who reads homicide inquiries for a living, almost. So perhaps I'm the wrong person to ask.
Thank you.
So there's a question in the chat also. This is from Kate. What is the process for designating a homicide as a mental health homicide? Doesn't that decision prejudge that there's a causal link between the perpetrator's mental health and action, rather than allow an open-ended inquiry in which it would be possible to conclude no causality specifically around mental health?
Thank you, Gareth, and thank you, Kate. Absolutely. If we were going to have a system of inquiries, we would inquire, we would have an open-ended sort of inquiry and not make any prejudgments. I think in reality that would be very difficult to do just because of the very large number. We have a number of homicides committed by people who've touched mental health services. And that's a very large number. And so it might be somebody who's perhaps once come into contact with mental health services 15 years ago and has never had contact again. It might be somebody who's in fact never had contact with secondary mental health services, but has received treatment for, say, depression or even psychosis by their GP. So in order, I guess, to make this a manageable process, what we've done for 15 years now is, in terms of national policy, is that if the person had contact with mental health services in the previous 6 months, then it, in a sense, that would qualify for further investigation. That's sort of the gateway, if you like. There are obvious problems with that approach. It means that others who might who might have been kind of very mentally ill, and perhaps there is some real learning in inverted commas to be achieved, wouldn't then have an investigation. And people who don't touch mental health services but are undoubtedly mentally ill and perhaps commit homicides whilst in care of primary care wouldn't necessarily merit a full investigation either. In fact, they might not merit any sort of inquiry or investigation. And the first point at which the mental health aspect becomes clear is when they're seen by a defense expert, for example, or whether they're in prison cells and are quite obviously unwell and are, if you see what I mean. So, I mean, as far as I know, the reason NHS England determined that it should be in the previous 6 months, contact in the previous 6 months, is just to manage the number, make it manageable. And it absolutely predetermines a number of things. I mean, the other thing I found, I'm afraid, in my research is that for those individuals whose primary diagnosis was a substance use disorder, were far less likely to merit an inquiry. And the cohort that was most likely to merit an inquiry was the cohort where the diagnosis was schizophrenia, schizoaffective disorder. So there is something, so quite a lot happens, I think, at quite an early stage, perhaps even unconsciously or subconsciously. So psychotic, mentally ill, inquiry, substance use, not mentally ill, and also people who commit offences, obviously, whilst under the influence of substances, are far, far, far less likely to succeed with a psychiatric defence.
Thank you. So we're getting, I think, towards the end now. Rob, I see you've got a physical hand up. We've got to end by asking you a little bit. I mean, we don't have to do this right now, but going back to Nottingham and how you're seeing that, and whether or not you would foresee the inquiry conforming to some of your recommendations. Some people seem a bit more hopeful about this inquiry than perhaps previous ones. I was struck very much by your points, your history of inquiries, which is that it started in 1984, which actually doesn't seem very long ago. I mean, that is to say there was a world without inquiries, not all that long ago. So perhaps I can draw you on that now, and then Rob, maybe you can have if you want, you can have the final question before we finish.
Thank you, Gareth. I mean, pre-1980s, there were inquiries, but there wasn't a systematic approach to mental health homicides in the way that we've had since the late 80s and early 90s. I mean, there certainly were inquiries, and I found some of those. I've even found the odd book, with the original report, but they tended to be much larger, larger inquiries, if you like, and were usually statutory. So there was no framework for non-statutory inquiries before the 80s, as far as I can determine. In terms of Nottingham, it's very difficult, isn't it? I know that I and privately many of my colleagues have said to each other, surely Nottingham's got to be, surely it's got to change things. I mean, this is the clueness of our times, isn't it? And surely it's got to bring about some much needed change in how we, I don't know, deliver mental health services. I have a large piece of work on recommendations and actions. And of all the work I've done, interestingly, the work on recommendations and actions, which was very tedious, if I'm honest with you, is the one that's attracted most interest from policymakers. So I need to get my act together and get it published somewhere. And I think the problem, I mean, Nottingham's obviously a statutory inquiry, and I've looked at non-statutory inquiries, but actually these inquiries have much more in common than not. And a key thing I found, which I found absolutely fascinating and was really struck by, is how recommendations are generated by inquiries. And there's a vast body of literature on inquiries kind of outside of health. And the thing I found was that, what the literature says is that inquiries that generate recommendations where recommendations are generated by 2 or 3 people, essentially the inquiry panel who sit down in a room, those recommendations are far less likely to be effective or evidence-based or have utility in the real world. And instead, what inquiries need to do is move away from that way of generating recommendations and invite experts in, sort of almost have a call for evidence, invite experts in, invite sort of key stakeholders and get people in a room, over several meetings or whatever, and say, right, this is what we found. How do we change the system? That's the question that inquiries need to be asking. And I suppose I'm sure we've all seen early signs that the Nottingham inquiry is looking to do it that way, which I'm very sort of heartened by. And I'm very much personally hoping that we will not have recommendations about risk assessment and care planning, although from what we've learned about the events in Nottingham, there certainly needs to be some thought given to what we mean by care planning and what we mean by continuity of care. So there's something about, I'm very struck by how we seem to have forgotten that schizophrenia is a relapsing remitting condition, and we seem to treat it like some sort of an episodic, so this person's had a relapse, now let's patch them up, throw them out, forgive my language, but that's what we seem to do in mental health services now, instead of remembering that schizophrenia is, as far as we know, a lifelong condition. People will relapse again and again, and therefore there's a good reason to keep them in secondary care services. I appreciate the moment I say there's somebody will say there's no money for this. I kind of get all that. But I'm hoping that this is one of the things Nottingham will draw attention to.
Thank you. So I think, Rob, we'll call yours the last question and then bring things to an end.
Yeah, thanks so much. I don't know if it's my Wi-Fi or yours, but I had a freeze there. So if I suddenly freeze, then, well, whatever. But I think the point you've just made to some extent was the point I was going to make. And it was sort of following on from your point to saying, as a forensic psychiatrist, my general psychiatry colleagues feel X, Y, and Z. And I think that as a general psychiatrist, I think I absolutely would want to second that. And coming back to my point about us discharging up to 2/3 or 3/4 of this cohort to primary care and seeing that as, I don't know, the recovery model or whatever it was economic, it was lots of things. And I know, having been in fairly senior management roles, having doctors writing to me, expressing the moral harm that they're feeling, both in the community and on the wards, when, for example, in our area, you can't get people into hospital for sometimes months at a time when they're seen as very risky to give exactly the psychosis treatment you're talking about. Or on the wards, subsequent to a homicide, someone gets, as you say, years of care onto depots and clozapine and so on. But yet on a general adult ward, they'll be under pressure to leave within weeks. And I think that system level analysis of, is this system actually creating more homicides or definitely more violent outcomes, is something that I think we all feel needs to be answered in a quantitative fashion.
Just to say, I agree entirely, Rob. Thank you.
Okay, well, I think we'll bring things to a close after such an interesting, rich presentation and discussion, Mayura. Thank you very much from all of us at the Maudsley Philosophy Group, and we hope you'll engage with us going forward, because we certainly hope you have influence conceptually at the policy level. So,
thank you.
Virtual clap.
Thank you very much. Thank you, Gareth, and thank you, everybody. I really enjoyed that. Thank you.
Thank you. Bye.